Okay, good morning, everyone. Well, at least those who are on a European time zone or similar. Um, Thank you for taking part in this webinar, which is a third in the series of our 4 webinars on the Handbook on Social Participation for UHC. This webinar is going to be on the topic of legal frameworks for social participation within the health space. And for those of you who have not heard about the handbook before, I'll just say very briefly that we have webinars that were done to give an overview of the handbook a couple of weeks ago, and those recordings can be found on the Health Systems Governance Collaborative website. But I will give you a very brief overview, assuming that some of you have not heard of it. But first, I'd like to introduce myself, and my name is Deepa Rajan, and I'm a health systems advisor in the Health Systems Governance and Financing Department at WHO headquarters. And we've been working now with the team here. I have with me online Kira Koch, Katja Rohrer, Chonga Bajnowski, and Anna Socha, all who are on this team working on this handbook on social participation for UHC. And we've basically spent the last year and a half actually reviewing the evidence, looking at secondary data, the literature, but also looking at primary data, which we collected in 9 countries across different WHO regions, where we did largely qualitative, they were all qualitative studies, and so we have a huge data set of primary data that we've also analyzed or are in the process of analyzing as we write these chapters. And the idea is for this handbook to come out in a couple of months later this year. So this, very quickly on the handbook, I think the key points before we launch into the topic of legal frameworks is that this is a handbook aimed at policymakers, at member state governments. They're our target audience, and the idea is for this book to be a sort of best practice guidance document on how to more effectively engage with populations, communities, and civil society for purposes of health policy making around the topics that are key for universal health coverage. And this is partly why policymakers are our target audience. And just to preempt the question that we always get, which is why aren't civil society our target audience? And that very question was subject to great discussion within our external advisory group, which is accompanying the development of this handbook. And to make a very long story short and not get too bogged down in that discussion, there was a clear agreement that there is a gap in guidance for policymakers, and that decision makers do need to be targeted in terms of this topic of how to consult with populations and engage with populations for policymaking. So without further ado, we'll start with this topic of legal frameworks for participation. Next slide, please. So there are lots of different legal frameworks and laws that are relevant for participation. Now, this list that you see here on your slide is not an exhaustive list, but in our review, and we also sifted through quite a bit of actual laws and directives and frameworks. These really crystallized out as the main ones that are relevant for participation. What is a legal framework? Because basically a legal framework is a law or a framework law that is more specific than a constitutional provision. So beyond principles that might be laid down in a constitution, they also lay down certain obligations. Now, it's still a framework, a legal framework, a framework law. So in some places, further legislation might be required to give effect to the legal framework. But basically what we'll see in the course of this presentation is that boundary between what is or can be included within a legal framework and what can be, what is left vague purposefully to be included in follow-up legislation or policies, that boundary is quite blurry. And as we'll see in the course of this presentation, we will make the case for legal frameworks to have more rather than less detail in terms of participation, for reasons that you'll see in a few minutes. So let's go through some of these types of laws just to give you an idea of what they are, and then we'll go into some of the aspects more linked to participation. So this first type of law, decentralization legislation, this is one of the the key pieces of legislation where with participation really at its center, at its core. Decentralization is basically a transfer of formal responsibility and power to make decisions regarding health services and the health system. So the management and financing, the production and distribution of health services. And usually that transfer of power goes from a smaller number of geographically or organizationally separate actors to a larger number of actors. So usually this is about going from central authority to regional and local authorities. And across countries, across regions, there's quite a bit of documentation on decentralization efforts in the health sector, and they all demonstrate that this legislation can be really a powerful creator of and a contributor to a participatory space and culture. And indeed, that is one of the stated rationales of decentralization, is to bring governing closer to the people through a structured platform that is placed locally to ensure more input from populations, to ensure more population voice in policymaking. And most decentralization legislation, and this is important, explicitly mandates some form of participation. But again, the level of detail and the actual authority conferred really varies greatly by context. And just to give you a couple of examples, the South African Municipal Systems Amendment Act and the Municipal Structures Act, which basically confers authority to municipalities. Basically, it states that communities must contribute to municipal decision-making. It states that municipal councils must consult with local committees. But it's left at that. So it's contribute to, it's consult, they must be consulted, but it's left at that level of detail. So without follow-up policy frameworks or legislation, that vagueness can be interpreted in different ways. In Greece, on the other hand, the decentralization legislation from, I think it was about 20 years ago, there's quite a bit of detail in terms of the composition of regional health councils, the terms of office of each of their members, the selection procedure, and the budget. So as you can see, there's a big variation in the amount of detail in the actual legal framework. But in general, the theory, as expressed in most of these frameworks for decentralization, is that community participation and people's voice are expected to be amplified by this new decentralized administrative status quo in the country. The next set of laws are right to health laws, and this concept of the human right to health is really inextricably linked to participation. There's extensive human rights literature documenting international, national, and regional treaties, and all include a notion that in order to realize people's rights to health, they must have a say in health. And an important point here is that the responsibility of the state is also highlighted in these frameworks, and that responsibility is to ensure a functional and adapted institutionalized mechanism for the population to participate and express themselves on health matters. Now, some scholars even go further, and they frame participation as not only inherent to the rights-based approach to health, but they see participation as a human right in and of itself. And there is an acknowledgement also in the human rights sphere that the right to health obviously cannot be delinked completely from other rights as well, such as civil rights, political rights, economic, social, and cultural rights. And this is particularly relevant in terms of the ease with which participatory activities can take place in countries. I think it's important to note here that the right to health is not really the same as the right to be healthy, but rather it's the right to have access to the actions necessary to be healthy. And in one of the, actually the first constitution to formulate that very right was the WHO Constitution of 1946. And that was soon followed by numerous national level constitutions. And this is a key point because the fact that it's manifested in national level legal frameworks means that, at least in theory, that participation through institutionalized mechanisms can be claimed as as a right, can be claimed as integral to the right to health. And can be claimed from whom? That's the question, and that's from government, because government is the duty bearer for realizing that right to health. So they have that obligation to put in place these participatory governance mechanisms, at least according to the right to health legislation, and ensure their functionality. The next set of laws are health acts, and participation and community involvement in health related decision making is often included in health acts in many countries, thereby providing that legal framework for participatory processes in health sectors. We see this a lot more in legal frameworks in health acts where there is a strong public health service. In Thailand, for example, the National Health Act of 2007 was really pivotal in kicking off a more institutionalized culture of participation and anchoring into law many of the local level participatory efforts that were already taking place. So giving them not only a boost in terms of resources and visibility, but also in connecting those local efforts more systematically to national level policymaking. And more importantly, it founded the National Health Commission Office, which is given a legal mandate through the National Health Act to run the National Health Assembly every year. Another example, again, South Africa's National Health Act created the health committees at primary healthcare facilities. Of course, this national level act is left very much as a framework act that needs to be given effect by provincial level legislation. So that has hampered the true implementation of some of these health committees. The UK has the National Health Service Act and the Health and Social Care Act. And again, the level of detail varies in terms of the stipulation of participatory activities across the different asks. And some really give specificities according to which population groups and stakeholders have to be included, and and some leave it much more open. And finally, I'd like to mention freedom of information legislation, because in many countries, this has really been a key tool for populations, communities, and civil society to access the information relevant to the implementation of health policies in their community. And having information gives civil society, gives community groups the ammunition, if you so will, to be able to dialogue with other actors in the system, and especially government. In Mexico, for example, freedom of information legislation allowed civil society to obtain basic information on health budget transfers between central and state governments, giving them the necessary information and evidence to put that on the dialogue table with government. And it really played a key role in the success of Mexican civil society creating so-called invented participatory spaces, which means those that are claimed by civil society, which then ended up with the sort of domino effect to open up so-called invited spaces, which were those that then governments put in place and started institutionalizing. Many social accountability frameworks include access of information as a key right and a key aspect with integral to the rights of citizens to engage with the administration, engage with governments through these public collective platforms. So I think, the point here with all of these frameworks and laws is that in the end, we know, and especially with freedom of information laws, information and knowledge is a source of power. It's a source of legitimacy, also for experts and professionals and governments, because without it, you can't really make rational decisions. So now allowing that same information and knowledge access to civil society facilitates the possibility of the latter being more on a level playing field with experts, and thereby facilitating true influence on decision making within a participatory space. Next slide, please. When we looked at these different kinds of legislation across different countries and looked at our primary data from our case studies, we looked at the literature, I think some key messages definitely crystallize out, and these are issues for policymakers to reflect on, and and ideally it would be, of course, in the lead up to a legal framework, but even where in countries where a legal framework is in place, I think these are issues that that need to be thought through. And I think and and the first one I think is it's fairly obvious. You can do participation without a legal framework. You don't need the legal framework in order for participation to take place, and we have countless examples of participatory spaces being created, of participatory activities happening, of communities organizing themselves, of even local governments organizing these spaces without a legal framework in place. A larger example of that would be what's happening now in Tunisia with the Societal Dialogue for Health, which was created, or which was born out of the post-revolution population grassroots movement, and has been ongoing since then for 6, 7, 8 years now, and is not anchored in any legal framework. And so what the point here is that obviously there's a point at which a legal framework might be useful, and there's definitely, and one message that I'll be giving you in the course of this presentation, that it's still better to have it rather than not, but it shouldn't be a factor to not do participation because a legal framework isn't there. Secondly, even when you do have a legal framework, it doesn't guarantee that participation actually happens. And of course, you don't have to look far to find examples of legal frameworks in various countries that haven't been implemented within the area of participation in health, or even otherwise. I mentioned South Africa just now and the National Health Act, and it did mandate primary healthcare facilities to maintain health committees, but the issue was that provincial legislation needed to give effect to that national act in terms of especially in terms of the health committees, and that they've been slow to come, and sometimes they took over a decade. And in some provinces, for example, the Western Cape, that legislation was only passed in 2016, so a full 12 years after the original National Health Act. And even with the provincial follow-up legislation, a lot of provinces still don't have these health committees in place and functional. On the other hand, you see, for example, in Portugal, the Basic Health Law of 1990 mandated a National Health Council, but it was actually only put in place in 2017, so 27 years after the original law was in place. So you can see that legal frameworks obviously doesn't guarantee participation, and many factors are usually in play when we see faulty implementation or non-implementation, and a lot of it is about the reigning political and societal culture, which might not view participation as a priority, and which may be interpreting some of the principles and obligations stated in a more open or vague way differently. And then there's, of course, the issue of lack of political commitment, or sometimes the lack of real grassroots pressure or demand for participation, or it might be a combination of both. And so there we go to our next point. We do know that power structures which are entrenched in society and culture are one of the hardest things to overcome, and a legal framework may not be enough to do that. And a series of papers from Guatemala, for example, examined looked at indigenous communities' access to health, and the systematic exclusion and discrimination that they faced obviously resulted in very unequal relationships in these participatory spaces. So when marginalized populations confront that embedded power structure, what we see is that a legal framework alone, in and of itself, without other aspects which we'll discuss in a second, is not enough to overcome those socio-political forces and that perpetuate that status quo. And the argument that I'd like to make in the next few slides is that those are the aspects that need to be thought through and stipulated a bit more clearly with more detail in legal frameworks in order to have a good chance at meaningful participation. several several studies from Brazil also noted that laws ordering participation of communities in the planning of public services, didn't really change the social hierarchy and some embedded prejudices, discrimination, especially in that social relation between professionals, health officials, and those who are usually the targets of health policies, those who are usually bringing down the health indicators and health outcome numbers. And because professionals, health officials, governments are usually those that they may come more from majority communities. They're usually those that are better educated, and those who are the targets of health policies are those who are the groups whose health is targeted to be improved in order to improve overall health in the country are usually those who don't have any of those characteristics, who are usually less educated and coming from marginalized community. So the point here is that these underlying challenges and power imbalances, if they're not acknowledged and counterbalanced somehow through the legal framework, then meaningful participation is definitely more difficult to take place. And finally, one thing I'd also like to mention, because we've seen this in a lot of countries, Tunisia as well, also in a lot of African countries, Asian countries, is that Europe as well. A big barrier that besides government cadres and civil society, a big group, stakeholder group in the equation are health professionals and experts. And the findings from several studies really repeatedly highlight that health professionals and experts have difficulties if they're not used to including lay citizens, lay people, civil society into planning and management activities within the health facilities, they very much don't see the point, or very much see this as an expert task. Management of health facilities, anything related to health services is really seen as an expert task. So there's a lot of capacity building that needs to be done on that side, and collaborative work with health professionals in these participatory spaces in order to adequately implement a legal framework. The next point is that we still think that it's better to have participation embedded in the legal framework rather than not. Even though, as I just mentioned, especially in government-led institutionalized spaces, there is always that risk of being captured by the elite. There is that risk of the better educated and better off accessing those spaces, and not necessarily those who are the targets of health policies. But what we also see is that if you have a legal framework in place, you have a right to claim. And here we're not talking about legal frameworks that explicitly exclude certain groups. So we, unfortunately, around the world, we're seeing a lot more of these frameworks that have the actual intention of the opposite of participation. So obviously those are the clear-cut cases. We're not talking about those cases, but those legal frameworks that talk about decentralization with the principle of participation, right to health legislation, health acts that have the intention of providing universal health coverage, freedom of information legislation, as faulty as they may be and as vague that they may leave things to interpretation, it still is better to have it than not, because it enshrines rights that can be claimed. And it also means that those governments who may be more favorable to participation can more easily put in place structures for institutionalized participation, or strengthen those that exist if there is a legal framework backing them. And a case in point, again, is Portugal, where, as I said, even though the actual Health Act dated to 1990, in 2017, when they did finally accord an actual structure and have give access to a budget, it was much easier to then put that in place because a legal framework was existing in the first place. And finally, when you have a participatory structure and institutionalized under law, then there is a certain safeguarding of that space where communities are then able to form their own collective identity and community voice, and at least in theory, as faulty as they may be in practice. Next slide. When we examined our primary and secondary data, we wanted to get a sense of whether there was a sort of a right moment for a legal framework, whether there were some commonalities in the windows of opportunity seen across the different countries and settings. And we've sort of teased out a couple of aspects here in order to answer that question. And one, it seems that grassroots pressure and support as basically a demand for participation is definitely one aspect that influences that answer of when is the opportune moment to have put a legal framework in place where there is not one. So again, going back to South Africa in the apartheid area, the struggle for freedom included that struggle, that assertion of a human right for health, and which had been, of course, ignored for many Black South Africans and others during the apartheid era. And so civil society organized to provide health services in that vacuum, independent of government at the time, and and created their own community participation mechanisms and acted as liaisons between communities and health services. So so this experience, obviously, this was a movement, a grassroots movement, where the right to health was embedded in it. And so when the new democratic government came into place in the early 1990s, community participation was included in the laws and policies at various levels throughout the 90s and the early 2000s across different sectors, but also health. And so here the grassroots movement was clearly present, and that long experience of collaborating within communities and with communities and forming civil society was then formalized through the legal frameworks that set out the key principles underlying health system development in the new South Africa. Now, of course, the implementation later on and to this day is definitely not perfect, but there was that opportune moment in that broad scale movement for democracy to include that right to health and participation within the legal framework. Another example is, again, Tunisia. I mentioned earlier that the Societal Dialogue for Health, which has been ongoing since 2012, 2013 now, so quite a while, and has weathered several ministerial changes and government changes because of that grassroots pressure and support, and that it has enjoyed. And this is a large-scale population engagement mechanisms for health, and they conducted through this large-scale consultation mechanism and engagement mechanism. They did the first big health system situation analysis in a participatory way, and also drafted the first post-revolution national health policy, which was presented last year in the National Health Forum. Now, there's a lot of discussion in Tunisia at the moment about, well, is it now the right time to put in place and start thinking through a legal framework, because this has been happening now for several years. There is a grassroots movement, there is support, and it has weathered so many different government changes and ministries, but there's still that risk that the next government would want to come in and potentially, at least attempt at removing its influence or removing it altogether. So this is probably an opportune moment in Tunisia to put that legal framework in place because of that grassroots pressure, that grassroots support, the visibility it enjoys at the moment. Thailand is another good example. When the National Health Act came in place in 2007, it was preceded by 10 years of civil society activism on a reform movement and a call for more participation in policymaking. And so those are examples where, when that's there and that pressure is there from the bottom, that gives you that window of opportunity to start those discussion on legal frameworks. And linked to that is really this larger reform process. Again, that was the case in Thailand, in Tunisia, as well with the post-revolution context, in South Africa with the post-apartheid era. Often that larger reform process is another key aspect in when a legal framework sees its window of opportunity. And in Kenya 10 years ago when decentralization happened, with the new constitution as well, there was a lot of talk about that principle of decentralization, which is being closer to the people. And so this is where that opportunity is clearly there to enshrine that right of participation within health, and as possible with as much detail as possible, favoring participation beyond the principle itself, including a budget, including resources and staff. And the final point I'd like to make here is that legalizing and validating existing practice, and that's also linked to the reform process, it's linked to grassroots pressure, is another important aspect of when might be a good moment for a legal framework. Going back to the example I cited earlier on Guatemala, there's a really beautiful series of studies coming from this one mountain community in a municipality called Palencia. And it shows, showing how community participation mechanisms locally organized were leveraged to provide better public services. But when these mechanisms were informally in place for a long time, but when the decentralization legislation came in, it then explicitly mandated those mechanisms which were already informally in place. And so it was a clear opportunity which those communities were then able to take advantage of because of the already existing mechanisms, but it gave those informal mechanisms a boost in terms of legitimizing them, giving them access to more funding, to capacity building, and allowed them in some places to really function at a much more sophisticated level than they were at the moment. And when that's happening, region-wide or country-wide, that's a moment to say, let's, a legal framework might be needed to sort of legalize and validate that. Next slide, please. So I had mentioned that, granular details do matter, that, we would like to see more rather than less detail favorable to participation in legal frameworks. So that careful design of the framework is important. And why am I saying this? It's because that's what we really see in our data and in the literature that we've analyzed, is that this matters quite a bit in the end in terms of how far participation is truly meaningful. When the framework is left fairly vague, obviously it's more malleable to political will. And what we see is that it's often then not implemented at all, or implemented without the necessary prerequisites, the necessary structures in place, or it's organized with little reflection and quite a bit of elite capture. And again, and this we repeated quite a bit in the last webinar, and the one before that even as well. Again, a participatory space in the end is imbalance in its at its core. In the starting point is imbalance, and making it meaningful is about getting that playing field to be more level. That's not a given. We've mentioned that there's a lot of inherent hurdles that are faced due to societal, cultural issues, but many other hurdles as well. So the type of detail which is needed in legal frameworks are those that help balance out those unequal power relations, which in the end can hopefully lead to more fruitful and frank discussions, because the point is really to have those frank discussions and that lead to feasible policy options. And so the three issues that for us, seemed really clear, which need a bit more detail and in legal frameworks. And this can be either in the original legal framework or in follow-up in places where these frameworks have been existing or are in place for many, many years. It might just be about follow-up legislation or policy frameworks. And those issues are, number one, the clarity in roles. And the literature is really rife with examples on the ambiguity faced by those taking part in participatory mechanisms regarding their roles and responsibilities. And basically codifying a role within a legal framework means giving that person or that institution taking on that role a certain authority and thereby a certain legitimacy and influence. And so especially for civil society and communities, that role clarity is really necessary. So what kind of input are they supposed to give? Which role are they supposed to have? How does that translate into outcomes of the deliberation? And you know, one example is with the National Rural Health Mission, which, you know, that framework in India, where many studies looking at the National Rural Health Mission, including our own, where we did collected primary data, where we looked retrospectively at the National Rural Health Mission, where we definitely saw that there was an ambiguity of roles between health managers and the community health workers, the ASHAs, the accredited social health activists, ASHAs, and which led to a lot of these ASHAs not really taking on their role as effectively as they could. And also there were new structures created by the NRHM, the National Rural Health Mission, such as village health and sanitation committees and many others, but there was but many stakeholders that we interviewed, health sector stakeholders, were unclear as to what each of these different mechanisms were supposed to do and what the people in those committees were supposed to do. So that role clarity, you know, wasn't stipulated in in detail in these in the NRHM frameworks, and in some states where the implementation was definitely much better, there was a lot of follow-up policy frameworks and documentation which did stipulate that, which made it, which contributed to the fact that there was more clarity of those roles and better participation. Decentralization literature is full of examples of the lack of role clarity when it comes to tasks and authority delineation between central and decentralized entities. And, you know, and sometimes in the decentralization framework, this role delineation is really mentioned in very broad strokes and, you know, with principles, with no follow-up accompanying measures or acts to bring that clarity. And especially where new structures are created where they didn't exist before, like health committees, with, you know, no experience with those kinds of committees and no capacity around it, of capacity to consult and to engage, that role clarity is really necessary in order to make the legal framework happen. And the consequences are really that those tasks then are not undertaken, or because of the confusion of who's supposed to do it, or unfortunately the fallback to the status quo where the authority is not really relinquished by the central authority, or not really relinquished by those who have them. And remember, the fallback status quo, when there's new roles and a new readjustment of those power relations and imbalances, is you know, is really going back to those who traditionally then hold that authority and make the decisions, partly because they know how to do it and they have been doing it, and there's no legal framework to explicitly challenge it. The second point is representation. We had a whole webinar about it last week, so I won't go into too much details, but basically the legal framework ideally should specify who should be included, what kind of input that person is supposed to have, what's their role and what's their influence on decision making. And some frameworks, one point I'd like to make here briefly is that what we see in a lot of the frameworks that we've reviewed is that sometimes there is some specification on who should be on who should be on these committees or institutionalized mechanisms. Usually that's the detail and specificity is given more to professional associations, medical associations, nursing associations, decentralized health authorities, regional health authorities, and less clarity is given on the side of who on the civil society side should take part, if at all. Financial and human resources, this is a key detail because you know, otherwise without a budget and staff to implement a law or a directive can't be implemented. In the National Health Act of Thailand created the National Health Commission Office with the budget and resources. Thailand's National Health Security Law created, which created the Universal Coverage Scheme, created the Community Health Fund, and also a Community Health Fund Committee, which the law gave power to approve budgets. And in that committee, there's it's clear that there needs to be local community groups, civil society representatives, etc. So that role clarity is there, the budget is given, and the representation issue is also covered. So that's a positive example. We'll move on to the next slide in the interest of time. In the decentralization literature, there's countless tales of lines of accountability not changing, despite the fact that authority and responsibility was supposed to transfer to local level. So this is what I mean by the functional structures that are necessary to ensure implementation. In one country, health officials, for example, remained accountable to the health department at the central level, because their transfers and postings were still controlled by the center, even though on paper they were supposed to report to the local government. So this is just an example, and in terms of participation, the more the lines of accountability don't go locally to those people who are closer to local communities, the less probability you have that participation will actually take place. Another aspect, and this is quite strong in the rights to health legislation and the freedom of information literature, is that there's a lot of scholars that advocate for independent institutions to enforce some of these, for human rights legislation, but also for freedom of information laws. And in Mexico, we saw that was one of the key institutions giving civil society actual aspect to information. The National Institute for Transparency, Access to Information and Personal Data Protection, the INAI, was key to actually realizing that right to information. And finally, some of the structures, the functional structures that need to be in place are really supervisory structures to provide support to civil society, to population groups, to decentralized entities, in order for them to be able to take on their new roles and, in that initial phase post-legal framework. And what we see, especially when they're in these legally mandated spaces, such as in decentralization legislation, is that all of a sudden a lot of these, there's a lot of entities attempting to do participation all at once. So there's a real need for that supervisory capacity to be put in place as a structure that's necessary to ensure implementation. And again, a lack of those structures means that implementation will be faulty. There's the risk of elite capture and control of political decision makers by various vested interests. And it's all about going back to that underlying power imbalance and uneven playing field. And of course, political will and the enabling environment is always a key factor in how far these legal frameworks are implemented. Next slide. And finally, capacities and the necessary capacities that are prerequisites for effective implementation. We have a webinar next Wednesday on capacities, necessary capacities for the participatory spaces. So I won't go into details so much, but really, I think the key point here is that major efforts are really needed in capacity building to ensure participation, especially within the frameworks of these laws that are being put in place, and ideally before the legal framework is actually enacted. And and the capacity building is also about awareness raising, about collectively being on the same page in terms of what the participatory space is and can be, and these capacity building initiatives can be a great facilitator of that. And again, support and supervision is really key, and the underlying message across all of this, across the whole book, but especially also within the legal frameworks, is to correct that inherent power balance within the participatory space, and a legal framework can really contribute greatly to that if the necessary detail, the granular detail, is enshrined in it, or in follow-up legislation that gives effect to it. Next slide, thank you. And I'll hand over to Kira to walk us through the question and answer session format. Thank you.
Thank you, Deepa, for the presentation. In the interest of time, I would say we directly jump to the question and answers. And we've already mentioned in the chat box that for all the questions that you have, please put in the questions into the chat box and make sure that it's to all panelists and attendees so everybody can see your questions. During the presentation, we already received quite a lot of your questions. Thank you very much. And Deepa, let me directly address some of you to you. We have a question from Bill Jeffrey, who is asking about the value of legal rights to participate in policymaking at the international level, especially at the World Health Organization, if civil society organizations do not have a standing at the International Court of Justice to enforce those rights. And maybe a related question, as we are aware that our handbook is more targeted to the national level, we have a follow-up question from Bill asking about the context of countries, authoritarian regimes and monarchies. What is to be said on legal frameworks in relation to those countries, in particular to legal impediments to consultations? Over to you. Deepa, can you unmute yourself, please?
Sorry. Thanks, Kira, for pointing that out. Yeah, thanks, Bill. We mainly looked at national level legislation in terms of how they were implemented or not implemented, and looked at the actual laws and what was actually included in those laws. We did look at international legislation in terms of how far they linked to and influence national level legislation, and definitely in the case of the human rights space, right to health legislation, there's a very strong link between what's going on internationally and what's going and how far or how fast national level legislation is then put into place or amended. And it is one of the the key pieces of legislation that gives that enshrines participation, at least as a principle, in a country's legal landscape. That being said, of course, it doesn't mean that it will be necessarily well implemented or implemented at all. At international level, in terms of the International Court of Justice, that really wasn't the within the remit of the handbook. I think, in general, even if civil society is able to claim rights and have them enforced at the international level through the International Court of Justice, and the human rights space, definitely that should and will most likely have trickle-down effects at national level, as it already has in with various treaties that have been signed by countries. In terms of the World Health Organization and the World Health Assembly, as you know, there is the FENSA, the Framework Agreement for Non-State Actors, and lots of ongoing discussions as to the role of non-state actors within the Health Assembly space. I hope that answers your question.
Thanks, Deepa. Another question that we received is in relation to accountability. Can you please explain more about social accountability, how to use social accountability framework on the road to universal health coverage, and if possible, any references that you can refer to? And I'm seeing that there was a particular interest to know more about the Brazil's Family Health Unit, if that's possible. Thank you.
Okay, so for social accountability framework, well, one that we looked at in detail as we are writing this chapter, which we haven't actually finalized yet, is, I think it's one by, I think her name is Rakshita Swami, and I'm happy to send you details. And from an institute in India, looking and basically laying out a framework of social accountability. And social accountability for me is similar to social participation, with an emphasis on that aspect of accountability and holding government authority to account. So it's looking at it more from the perspective of communities and civil societies, whereas we as WHO, a member state driven organization, are looking at it more from the angle or lens of the policymaker. But I think that, you know, there's a huge overlap, and the two are clearly complementary. The framework that I mentioned has some very key aspects laid out, including the right to information, including capacity building. So much of the topics that we're covering in this handbook with the chapters that are being presented in this webinar are all part of that social accountability framework. And I'm happy to, we're happy to send through a link and a reference on that. On Brazil and the family health units, we didn't conduct a case study in Brazil, so we didn't go in depth on that country. So the information that we have is mainly through our interactions with our regional office and through the literature. And I think in general, what we can say is that the legislation around the decentralization and creation of these family health, the family health units, definitely has put more power and authority to local governments, and how that plays out and the implementation is very, very varying across the country and very much depends on the local government. So it seems that the power is more within the local government and less within the people. So it's a transfer of authority from central to local, rather than from central to local and the people, unless except in those places where the local government has a good link to the local communities and has built the capacity over time, where those with community participation initiatives. And so I think the results are mixed, like we see in a lot of places, that it can, even in India, in some states the National Rural Health Mission communitization pillar work has been really beneficial to communities. In other places, it's just not really implemented, and a lot of it goes back to how far the local authorities have the capacity and have recognized the importance of that, of bringing communities in adequately into decision making. But in general, it's I think we can generally say that it's probably been more positive in terms of bringing in community views and participation rather than not, with all of its defects and faulty implementation.
Thank you very much, Deepa. Another question, and this is a question that actually came across in all of our webinar series, is the link to marginalized people and minorities. Here, this time in relation to law and regulation. It's a question from Chico from Japan. The law protects people and at the same time sometimes pushes further away from marginalized people and minorities. I would like to know some good example of legal framework countries to avoid such situation and we actually have an inclusive and participatory process.
Yeah, so as we repeat really in all of these webinars and also in the handbook, getting input from marginalized and vulnerable communities is a huge challenge, and they seem to always get left behind, even in the most well-designed processes and intentions. And so if that aspect can be thought through and reflected on adequately when putting in place a legal framework, we will have gained quite a bit, because then it's anchored in law that certain communities and certain groups need to be at the very least consulted, if not collaborated with, in order to make policies, health policies. A good example might be Thailand, although recent discussions with our colleagues in Thailand on the National Health Assembly have shown that even there, one of the aspects where they felt where they were weak, and this partly came through our own evaluation of the National Health Assembly that we did together with them, is that they also need to think through this aspect, even though that they have this very sophisticated process, so that they have realized that certain groups still do get left behind, and perhaps additional methodologies are needed to reach out to them. But at least what we can say in terms of marginalized and vulnerable communities and the legal framework, the National Health Act in 2007, what's really enshrined in that and is really positive for marginalized communities is that community groups and civil society organizations are mandated to be part of all working groups discussing resolutions on all steering committees, all technical committees, and really across all of the different decision-making steps along the way leading up to the National Health Assembly, they're a part of it. They're mandated to be a part of it. Now, how far that is functional is very much dependent also on their capacity and government capacity. And that's where the National Health Commission Office has a huge budget for capacity building. So, so that's something that's being worked on. And there's the Thai Health Promotion Fund, which provides core funding to civil society. So they're in a very privileged situation there, but that would be a good practice example.
Thank you very much, Deepa. A question that I think a lot of people ask themselves at the moment in the context of the COVID-19 pandemic, and this is a question coming from Sebastian von Gils. He's asking if there is an opportune moment for a legal framework. Do you think there's an opportunity after the COVID-19 pandemic recovery for member states to establish legal frameworks to support social participation in health decision making? Did you come across any example of this in your review of the literature?
So yes, and it's interesting, Sebastian, that you're asking that, because we had an internal meeting, discussion about this in our team, in the governance team at WHO about this, the health governance team, because I think, our world is radically changing. There's a pre-COVID world and a post-COVID world. I think all of us will agree with that. And how that, of course, the details and how the world is going to look after this crisis is over, we don't know. But one thing that we are seeing is that health is now a huge political priority across all countries. And B, that it's being, because it's such a big political priority, it's being raised up to, cabinet, prime minister, head of state level. The risk there is that potentially that level takes over coordination of health and health-related issues, and health experts and health ministries potentially get sidelined. We hope that's not the case, and we as WHO are aware of this risk and will be doing what we can to work with member states to not have that happen. The point is that health is going to be more important, and the governance of health is going to be even more important. And we see in, even in high-income countries like Europe, that somehow the threat of COVID was underestimated, that the spread was underestimated, and the reaction came too late. Now, if we had had participatory mechanisms in place to be in constant dialogue with the population and with civil society on health-related matters, perhaps this could have been detected earlier. Perhaps a recognition of the problem could have been made much earlier. And I think these are all issues that do provide an opportunity to potentially anchor a participatory approach to health into the health sectors in all of these countries post-COVID. And how far this will happen and will be taken by health as in the lead is the big question. And I think we all need to work towards that and make sure that is what happens. And I think WHO has a key role to play there, and we're very much aware of it.
Thank you very much, Deepa. I'm looking at the time. We have completed now our 1 hour of the webinar. Maybe if we are able to, I would just extend a couple of minutes and maybe take a last question for you to answer, which comes from Hizam. He's asking to tell a bit more about who are the public in charge bodies for ensuring how to implement social participation in health decisions. And this links very much to the first webinar actually that we had on policy uptake and decision making. So just as a quick note, we had a first webinar on this topic, but Deepa, maybe you can elaborate a little bit more on the public in charge bodies for ensuring how to implement social participation.
Okay. Yes, so I do, as Kira mentioned, we have the first webinar was on this topic, and the recording is available. the video and the recording, so please do listen into that if that's of interest to you. And when we talk about participatory spaces, it's a very generic term, and it includes quite a bit. It can include institutionalized mechanisms such as the Health Council in Portugal. It can include large-scale, more one-off events like in France in 2018, there was a large-scale 3-month consultation with the population on bioethical matters to revise their bioethics law, which included public hearings, it included a citizen jury, it included radio interaction with the population. So it included several mechanisms and online consultation as well. So all of these we're putting into this big rubric of participatory space. It can also be in health committees at local level. So what we examine in our data, in our evidence analysis is really all of these aspects, and so we looked at the modalities of participation directly with populations through the medium of civil society and engagement directly with civil society, and through community groups and community mobilization efforts, which happen quite a bit in the health sector, and where there's a lot of experience with it, especially in the vertical program space. So malaria, HIV, maternal health, etc., do a lot of work in working with communities for improved program implementation and service delivery. So we looked at those mechanisms as well. So in terms of your question of who's doing these mechanisms, we're very much focused on government-led mechanisms. So in a lot of countries, it was a Ministry of Health who might be using participatory mechanisms for a national health planning process. It might be like another health institution like the National Consultative Bioethics Committee in France for their bioethical consultation, for example. In Tunisia, it's a separate entity called, which is the steering committee for the Societal Dialogue for Health, which includes civil society and government, but they work quite closely with the Ministry of Health. So there are various entities. In Thailand, it's an independent institution. It's the National Health Commission Office, which has its own act, giving it its mandate. And they spent quite a few years at the beginning convincing the Ministry of Health in the first place that this National Health Assembly is actually quite useful for their policy work. So we're focused very much on government-led spaces and institutions because our target audience are policymakers, and we want to encourage governments to engage more effectively with populations and communities and civil society. And where the mechanism was more community focused or led, like some of these programmatic led interventions at the community level, our focus in our analysis was how far those voices that were being given and being heard at community level, how far were they taken up at national level and brought into the policy-making space at national level when the discussions were happening around policies in UHC.
Thank you very much, Deepa. I would like to close the webinar now, and I would like to thank you everybody who's online for joining us today. Please note, as I mentioned before, the recording of this webinar will be shared afterwards on the Health Systems Governance Collaborative website. I shared the link in the chat box already. A quick note as well, our next webinar will be on capacities for mutual beneficial engagements, which will take place on 1st of April 2020, so next Wednesday at 4 p.m. Central European time. And of course, we would very much like to have you part of this conversation next Wednesday. And a further note, which I had shared as well in the chat box, we are still in our ongoing consultation of the Handbook on Social Participation. The link I will also put into the chat box again for you, so please take part in the survey. We very much would like to hear your input in order to incorporate into the WHO Handbook on Social Participation for universal health coverage. With that, thank you very much, Deepa, for the presentation and the answers, and thank you everybody for tuning in today. Please take care of yourself and stay safe. Thank you very much.